Hello and welcome everybody. I am so excited today. We are going to have a very interesting conversation with Ryan, and he is a bioethicist today, and he's going to give us some extra information on euthanasia. Sometimes we have patients when we're talking about hospice, and they will assume that hospice is synonymous with euthanasia. And so I wanted to have this topic in order to be able to give some clarity to people so that we could have a better understanding. So Ryan, thank you so much for joining us today.
Thank you so much for having me.
You're welcome. Well, Ryan, please tell us and our audience a little bit about what it is that you do and what drew you to this field.
Sure. My name is Ryan Ferdyhert. I'm a bioethicist, clinical ethicist, and self-stylized philosopher with the Center for Practical Bioethics. I work as the Vice President of Ethics Services and will be the Sister Rosemary Flanagan Chair of Bioethics starting January 1st. Excited about that position. I'm also a Professor of Bioethics at Kansas City University in the Osteopathic Medicine and Master's Program. My work is very clinical based. My organization partners with hospitals, hospices, organ procurement organizations, a lot of different healthcare industries. And what we really work on is situations where the clear answer of what is right or wrong is not as straightforward as we would necessarily want it to be. And a lot of that comes with new advances in technology, new opportunities. We have programs such as our ethical AI initiatives on how do we implement AI in an ethical way, where we're seeing some of the ramifications of what that could be if you weren't to put it in a way. So we want to really focus on how do we do things and keep society and medicine moving forward while also keeping those humanistic values that we hold so important. So my background is philosophy. That's been my entire passion, my life. I've studied it my entire career. And when I was an undergraduate, I heard about a medical ethics situation for one of my professors, and I fell in love with it. The idea of taking ethical theory and putting into applied situations to actually do the good that we're hoping to achieve was a draw that I couldn't pass up. So I studied at University of Pittsburgh, studied philosophy, then continued my education at Creighton and Loyola Chicago. Then I worked at University of Pittsburgh Medical Center, and then after working at UPMC for a couple of years, I took a job in Seattle with MultiCare Health System. I was the head bioethicist for the hospital system, where I covered 9 different hospitals, chaired 5 committees. And then I came to Kansas City with the Center for Practical Bioethics. I oversee about 25 different hospital systems, give or take, of which those are systems. Some of them have many, many locations. I cover hospitals in Louisiana, Nebraska, Iowa, Kansas City, Missouri, and then we also have partnerships with other hospitals across the country. So my work is very going into hospitals, working with patients, working with physicians, administrators, writing policies, providing education, and a passion of mine. My number one passion would be language. I'm a philosopher of language. I really study, my main research is on what do words actually mean? What are we trying to do when we communicate? And what are we trying to do when we're explaining things with words? And euthanasia, hospice, passionate withdrawal of life-sustaining interventions, all these terms mean different things. And I think whenever I'm a student of, well, not a personal student, but Ludwig Wittgenstein is my favorite philosopher, and he argues that the meaning of a word is its use. We give words meaning based off the context in which we have them. So whenever we use these different words, a lot of times we'll find that patients will have one idea of what a word means, and then the hospital or the physician will have another idea of what that word means. And then we're communicating, but we're not actually sharing concepts. We're not actually sharing the ideas, we're sharing the words, and that can lead to ineffective communication, and that's where we have some breakdowns. And I find that this topic particularly of euthanasia, medically assisted dying, aid in dying, death with dignity, so many different words and terms, and they are used a lot of times interchangeably, but in the ethics world, each one has a specific use, a specific meaning. And if you're not using that effective communication, then you could have not as meaningful communication with patients as we would like. So that a lot of my work is on how do we have better conversations? How do we have better communication? How do we share better language so that we have more meaningful interactions with our patients, so that we can bring out the ethical permissibility or the ethical values of what patients want and what we're able to achieve medically as much as possible.
Well, Ryan, that was it's so beautifully said. And I agree with you so strongly in regards to the way in which words carry meaning, because I think that is a huge factor that often we dismiss. On a more global scale, I talk to patients a lot of the times about making sure that they understand things in a way in which they can understand it. And sometimes doctors, we have this tendency to walk into a room and, just explain, oh, well, you have heart failure and you're volume overloaded and you're this and you're this and you're this, and I'm going to start you on this beta blocker and this thiazide diuretic, and we're going to do this. And we've said all of the things that we needed to say in order to convey to the patient what it is that they have. However, if they didn't have 15 years of medical training,
Literally,
they're not going to understand what we just said a lot of the time. So, and I think especially when we're talking about end of life, hospice, euthanasia, death, dying, those things, the level of emotion gets ratcheted up a little bit in that regard. And so making sure that we're choosing our words as well as possible in order to convey what we mean is definitely very important. And so I'm so excited to learn from you today, Ryan. But with that, let's go ahead and dive in a little bit to this process. We've got a little disclaimer first and foremost. I always like to put this out there that Ryan and myself are here and we're providing this information for informational purposes only. We're not intending to diagnose or treat, and it's very important that you seek out your own resources from either your doctor or other resources within your health system. So a little bit about Wellspring Healthcare. Very important that we believe in the power of compassion and effective communication, going back to those effective communication words there, Ryan. And also empowering education to really transform lives, because I feel very strongly that if we don't have the knowledge, it's very difficult to make the decisions that we want to make or that we need to make. And so that's the reason why we put together these webinars and these processes.
Another great quote by Wittgenstein is, the limits of my language are the limits of my world, and the limits of our education, the limits of what we understand, narrows our world. So the more we know, the more we understand, the more we can experience, and the more we can get out of life and more we can get out of the world.
That's wonderful. That's wonderful. And with that, we always want to keep the conversation going, so please don't hesitate to reach out to us. You can get in touch with William, our medical assistant, at 816-708-1661, or please reach out to us on our website at wellspringhealthcare.org. So without further ado, Ryan, we have this definition here, or lack of a definition, but euthanasia is a complex and deeply debated topic involving both ethical and legal considerations. And, before we started recording, Ryan, you mentioned the way in which you think about euthanasia. And you said that you had these 4 different buckets. I was hoping you could explain that in a little bit more detail, because it was a very unique way of looking at it from my perspective, having never heard it that way. And so I'd love you to expand on that for me.
Sure, absolutely. So just a little etymology. Euthanasia means good death, peaceful death, comfortable death. And it really started with ancient battles. And you would have patients who, we didn't have modern medicine, we didn't have pain medicine, we didn't have all the abilities that we can treat patients. So death was a much more terrifying process, a much more painful process than it is now. So it was seen as releasing from suffering, releasing from that moment, where there's 3 different ideas when you think about death. There's dying, death, and dead. There's the process of dying, the action of dying, and then the state of having reached death. And for a long time, because of the lack of pain medicine, dying was seen as the terrifying aspect, and death and dead were seen as better because they were the release from the suffering. Where now, because we can manage dying so well, it's death and being dead is where the fear has. So we've kind of shifted our priorities. But when we think about euthanasia, and whenever as a ethicist I hear about euthanasia, I think of it as 2 different categories and mixing them together. So kind of like a grid system. There's active and passive. So active, in philosophy we call it action theory. It's, did I do something to cause something to happen, or did I do something to allow something to happen? Did you purposely do this, or did you let something happen? So an idea, a horrible example, but one of the examples is like if you're driving and you see someone on the side of the road drowning, did you drown that person if you didn't get out and save them? Well, no, you allowed that person to drown. So were you actively hurting them? No, but you do still have some moral culpability. And we call it ought implies can, that if you're able to do something, it means you can, if you're able to do something and have an obligation, it means you're actually physically capable of doing that something, which means if you are capable of doing it, now do you have that obligation to do it? So active versus passive, and then voluntary versus involuntary, of a patient saying, I want this or I don't want this, or an advance directive saying, I want this, while the patient's not able to communicate, or we're making assumptions of using like subjective judgment of, would dad or mom really want this? I remember we had a patient one time who dad went fishing every weekend, and he told his family, like, I'm going to die in that fishing boat. That is what I care about. That's what I want to be doing. And he needed to have a procedure done, and the family were not sure, should we do this? And he was going to be in a long-term care facility for the rest of his life if he had this procedure done and hooked up to machines. And they said, like, we don't think he would want this. Was dad able to say, no, I don't want that? No, but everything that they knew about who he was, who dad was saying he'd rather be in that fishing boat than he would be hooked up to a machine. So that is how we kind of like subjective judgment. So when we think about those interchangeable terms of euthanasia with active, passive, and voluntary and involuntary, there's voluntary passive euthanasia. And that is a patient saying, I don't want to be on a ventilator anymore. I don't want to do dialysis anymore. I'm ready to go. I'm at peace. I'm ready. That is a patient choosing to allow death to happen. That is a patient engaging with capacity, knowledgeable, and saying, I understand where I am. I understand what's going to happen, and I accept it. They're not going to do anything to hasten that death or cause that death, but whenever that death does come, they're not going to do anything to avoid it. They're going to embrace it and accept it. Then there's involuntary passive euthanasia. That's where the patient is not able to consent. This could be because of their condition. Maybe they have dementia. Maybe they're not able to really engage with this. Maybe if they had a brain injury, hit their head, and they're not able to communicate with us, but they're declining on the ventilator. Would they want to continue to be on the ventilator, or would they want to be taken off and allowed a more peaceful passing? If they're not able to look us in the eye and say yes or no, then we're called involuntary passive euthanasia. And then we get into where I think most people think of euthanasia is active euthanasia. This is where we do something with the intention of causing or hastening death. And that can be voluntary active euthanasia. That is what we see with medical aid in dying, death with dignity. I believe there's 11 states in the District of Columbia, DC, that allow it, where a patient can engage with the process of taking a medication that will cause their death. It is completely voluntary and patient participatory in multiple checkpoints and multiple safety measures to make sure that it is as participatory as possible. And then there's involuntary active euthanasia, and that would be like a patient not able to consent, on a ventilator, in a coma, and somebody deciding, well, this patient shouldn't continue to live. We're going to do a compassionate, active, doing something to cause their death. In the ethics world, involuntary active euthanasia is pretty much always seen as unethical, as not the right thing to do. I don't like to say absolutes. That's just a habit of being an ethicist, but 99.9% of the time, I maybe someone could think of a thought experiment would be okay, but for the most part, always seen as unethical. And then there's active or passive, voluntary passive euthanasia, where a patient is saying, I don't want this and I am ready for my death. 99.9% of the time, that is ethically permissible. Patients are always allowed to refuse interventions. Patients are always allowed to accept their death whenever it's time for them to go, and do it with dignity and peace and as pain-free as possible. So the problems we have are those two middle grounds. Voluntary active euthanasia. Can a patient choose to hasten their own death? Is that right or wrong? And then involuntary passive euthanasia, of if a patient's not able to say anything, but we feel that it'd be better for that patient to pass peacefully than continuing the aggression. Is that the right answer? So those two subjects are really the debate right now in the ethics world. The other two is pretty much settled, but those ones are where we really have some difficulty. And that's going back to what we were saying about language. I feel that if people were saying, well, are you going to euthanize my parents, or are you going to euthanize the patient? And I'm thinking, well, are you talking about voluntary passive euthanasia? Because I don't think that anyone would really have a problem with that. That's not the same thing, the same emotional response to when you hear euthanasia or euthanizing a patient?
Mm-hmm.
Or is it, oh, they're going to euthanize? Well, is it voluntary or involuntary passive or active euthanasia? So it's when we use the right terms for the right action that's going to happen, a lot of different ethics kind of come with it, and the way we interpret it really does matter. So the first thing that we would want to know if this kind of situation is happening is which category are we falling under, and
Mm-hmm.
how much level does the patient have? And that's when, if I were to be involved in a situation where a physician or a family member or a patient would say, I don't know what the right or wrong thing to do here is, that would be one of the first questions. How much level of participation does the patient have? Are they aware of this? What is their medical condition? What is their expectation? What's their prognosis? Where are things going and how are we expecting them to be? So we want to know all of that information as much as possible, and then we can kind of understand what is the ethical permissibility, the right or wrong, or the recommendation that we would feel as ethicists. But it really does come down to those four categories of where are we? What is happening?
Right. No, that's great. It really is a beautiful way of looking at it, and it's you're taking me to school right now, because this is a new way for me to think about things. You know, the first two that you described. So I'm going to try and say it the right way. So inactive and
Passive and active,
passive,
involuntary
right?
and involuntary.
Yep. So okay. So active, voluntary, meaning someone is. This might be an end-stage cancer patient that has stage 4 metastatic cancer and has been through multiple rounds of chemotherapy and is now electing to say, I don't want that anymore. Or you mentioned the person that's on dialysis. I'm tired of going 3 days a week for 4 hours, an hour in travel, an hour back in travel, 6 hours 3 times a week, 18 hours a week I'm spending on dialysis, and I'm tired, and I've had multiple hospitalizations, and I don't want that anymore. So that is someone that is choosing an
passive, because they're allowing that would be voluntary passive euthanasia, because that is a patient saying,
passive.
I don't want to die, but whenever I am dying, I'm ready to die.
Wonderful. And that's where I mostly consider our hospice patients.
That's where my world is. A majority of the time is these types of patients. The other ones are, I mean, I see them more often because I'm an ethicist, so I get the strange and the bizarre cases. But for the most part, that is most death is patients. I don't like to speak in hyperbole, but I feel that most patients have a very similar, and that is, do everything that you can that you think is going to help me, but whenever you get to a point that you don't think it's going to help me anymore, I just want to be comfortable and I'm ready for my passing. People don't want to die, like we said, but a lot of patients, whenever they understand and they get it and they get to that point, and maybe it just comes from the territory of working in hospice and healthcare a lot, they're actually very meaningful and heartfelt and beautiful moments when you see patients just embrace and accept it. And again, I'm a philosopher. They joke about the more you study philosophy, the less death you're afraid of, because it's something that everyone's going to experience. It's as natural as being born. Everyone's going to be born. Everyone's going to die. And we celebrate. We celebrate every life stage moving forward, and we don't celebrate death. It's something that we're all going to have to experience, but yet it's something that we're all afraid to experience. And it's mostly when we do embrace it and come to that reality of, I think that's what makes life so valuable, is the knowledge that we only have so much time. If you are sitting around and thinking about what are you going to do with your life, well, if your life were to go on forever, does it really matter what you do with your life, because there's always tomorrow? But if there's not always tomorrow and you only have so much time, now that your days become meaningful, now they have value because you only have so many of them. And I think that is the most, it's tragic, but it's beautiful that our life has value because we only have so much of it. So what are you going to do with the days that you have is, I think, the most important question that anyone can ask every morning.
That's a beautiful, beautiful statement, Ryan. Beautiful statement. All right, let's see what we can figure out here. Let's move on a little bit. So we talked a little bit, you briefly mentioned this in terms of the autonomy. So making sure that someone has the ability to be able to express their own wishes. And so that was where you were talking about, help me with your terms that are new to me, Ryan.
That'd be a voluntary. Voluntary implies if patients voluntarily participating, means they are engaging with their autonomy. They are expressing their medical wishes. Autonomy, the right to self-determination. Patients are allowed to have the medical care that they want. You can't force patients to have surgeries that they don't want to have. It doesn't mean patients can demand things. It doesn't mean we talk about like non-beneficial care. If a patient had a stomach ulcer and they said, I want chemotherapy, no, we don't do that. So we do things that have benefits, but we don't do things unnecessarily. But we also want to make sure that, does this patient understand what their diagnosis is, what their prognosis is, what the expectations are, what recovery would be? Are they aware of everything that goes involved? Because it's that patient's life, their experience of it, and it's their medical wishes. So in the ethics world, it's a high ethical principle of patients need to be able to engage with their own healthcare and as much as possible. And we also say that when a patient loses capacity or the ability to communicate their goals, that doesn't mean that the principle of autonomy goes away. It just means it gets much more difficult to know what that patient would want. But that patient's right to their own medical wishes are always there up until the point of death.
So Ryan, help me a little bit. You used an example earlier about a patient who had expressed very clearly to their family time and time again that I want to die in my fishing boat. That's what I want to do. And if he was going to have a surgery, he was going to end up in long-term care, most definitely, and doing those types of things. So if that patient is incapable of making that decision at that time based upon, being intubated, for instance, and being on pressor support and, or having metabolic encephalopathy from their underlying infection, which is the reason why they need surgery in the first place. How are we respecting the patient's autonomy in that situation? Are we doing it based upon their previously expressed wishes?
So we use a hierarchy, 4 steps. The first one is always patient with capacity. It's always best when we're trying to make a medical decision of a patient to look you in the eye and say, I want this, I don't want this. When we don't have that, then we have to go down to, we call it precedent autonomy. That's an advanced directive. A patient saying, I do not want to go on a ventilator. I do not want dialysis. They haven't communicated that decision or directly where this moment is happening, but they're saying their entire lives, they've documented it. This is what my wishes are when I get to this point. That is that patient speaking through a piece of paper. Rather than a patient looking at you and speaking, it's them speaking through the paper. Then we have substituted judgment. That's where we don't have what their wishes are, but we kind of know who they are as a person, and that would be dad in the fishing boat. Would dad saying, I want to die in that fishing boat, is that him saying, I want to continue dialysis? Is that him saying, I want to have this aggressive surgery? No, that's not him making a medical decision, but it is expressing him as the character of his personality, of what he does value. So we call it donning the mantle of the patient. If you put on the patient's hat and say, if I was the patient, what would I say? And you think, dad always said he just wanted to be in a fishing boat. He wouldn't want to be living a life where he couldn't be in that fishing boat. What would dad say if he could talk right now? He would probably say he'd want to be in that fishing boat. So it's trying to assume that answer. And then we have if we don't have that, we have what's called the best interest standard. And it's just a risk-benefit analysis of what's in the best interest of this patient and what's not in the best interest of this patient. But that's when the patient can't communicate, we don't have any documentation, we don't know what their wishes would be. It's what are we going to do when we have no idea? And we really do not enjoy having those kind of situations. So when we do 2, 3, and 4, precedent autonomy with advanced directive, substitute judgment, or best interest, we use a surrogate decision maker. And that's a family member or a friend or someone designated or assigned based off state laws on who can speak for that patient. And another thing that we want to keep in mind is when you are serving as a surrogate decision maker, you're having someone be your surrogate decision maker. They do not make decisions for you. They make decisions as if they were you. So they're not supposed to say, well, I don't think dad would want that surgery. Or, well, going back to the fishing boat, I want dad to live and I like dad. So I want dad to live as much as possible. Dad should have that surgery. Is that speaking for what dad would say? Or is that speaking for what the surrogate decision maker would say? So what is truly upholding that patient's autonomy is that patient's voice coming through the surrogate decision maker. So they would say, I want dad to live. but I know Dad would rather be in the fishing boat. I know Dad would not want these things. So Dad would say this. And you have to go with what would the patient say if the patient was able to communicate.
I love that's great. You do a wonderful job of helping to clarify that. That's why Ryan is our expert today. So he's really helping us to understand all of these different principles. And I think these principles are really important when you're looking at a hospice perspective, because it's a lot of terms that people aren't comfortable with. It's a lot of terms that people don't fully understand. And I've been doing this for almost 20 years now, Ryan, from medical school to residency to now practicing for, an extended time. And these things are all very challenging. And I've been doing hospice for, over a year and a half. And so it's, you get into a pattern of being able to speak with people and understand things. But I love having the additional knowledge base that you're providing for us today.
Well, when bioethics, kind of the adage of the field is, just because we can, does that mean we should? Where medicine is amazing and it is advancing, and there are so many things that we can do, but does that mean we should do? And one of the things that define what we should do is, well, what would the patient want in this situation? Should we do this? We can do another round of chemo. Is that what the patient would want? And those are the questions. So I think medicine is really, really focused on, at least in society, what we can do, but we don't have enough conversations about what we should do.
Very interesting. And I often believe that sometimes the treatment can be worse than the disease process. And I think that goes back again to what you were mentioning before about death, right? That it is a natural process of life, and it's the one aspect of our life that we don't celebrate, because I think, like you said, a lot of fear comes into that, and people aren't appreciating the beauty associated with that, because our lives are beautiful, because they are fragile and they are finite. So very much so. All right, let's touch base on these two terms here, beneficence and non-malfeasance. And so this comes back to avoiding harm. So in this situation, I think it goes all the way back to what you said at the very beginning about the etymology of the word euthanasia, in the sense of, avoiding the death and dying process was so painful at that time that would not have been considered harm per se. Am I understanding that right? Or
I mean, it really,
with that?
It comes down to if you have like a soldier on the battlefield who has a mortal wound, and it's going to take them 20 hours of bleeding out and getting infection, or would you put your sword quickly through them? What would be a better death, where the death is going to happen and that soldier could be in non-stop pain? To euthanize that soldier would be a good death. It'd be a better death. But you're bringing up, again, those words. What is harm? Beneficence, we're supposed to do good, and non-maleficence, we're supposed to minimize harm. Well, what is harm? And that's kind of, I think, particularly with the ethics of euthanasia, when we think about these ethical principles and we say all patient situations should uphold all ethical principles, but then conflicts can happen where you can't do both. And that's when we have what we call an ethical dilemma. And I think euthanasia brings up those questions of autonomy versus beneficence, of a patient saying, I'm ready to die, please do something to help me die faster. Well, should we value that patient's right to self-determination? Should we value what that patient is saying? Or do we have another obligation of, should we do good for this patient and not do harm for this patient? And then that brings into the next level of, is death a harm? Some people believe that death is always a harm. There's no such thing as euthanasia. There's no such thing as a good death, that every death is a harm. So it should be avoided as much as possible. Where others believe that, as you said, sometimes the treatment is worse than the disease. Sometimes the cure is worse than the death. So is death in those situations, and this is, again, my subjective judgment and my bias. I've seen a lot of death in my career. I've seen a lot of bad deaths, and I've seen a lot of really, really hard deaths, and I've seen a lot of really, really good deaths. There can be good deaths, and there could be times where when someone accepts it and is happy and embraces their own mortality, that is a good death. When they're struggling and it's difficult for everyone involved, that could be a very, very much more challenging death. So is accepting of death, is that doing good for a patient, or is that harming a patient? Can death be non-harm?
Well, I totally agree with that, Ryan, because I think it's so interesting. We see this a lot of the time in hospice, is we'll bring somebody onto hospice who voluntarily selected that they want to be on hospice. So they voluntarily are active participants in that process. And then they end up getting a bad urinary tract infection and become confused, or something of that nature changes. And someone at the facility or nursing facility or whatever the case may be didn't realize that this patient was on hospice, and they subsequently transport them to the hospital. And while at the hospital, they get labs drawn, they get IVs started, they get antibiotics initiated, and all of these things happen. In the meantime, all of a sudden we find out, oh wait, this patient was on hospice, and they expressly wished to not have any of these things done. So I look at those situations as like, well, we just created harm to this patient, even though we wouldn't necessarily think of going to the hospital, getting IV fluids, antibiotics, and labs drawn as harm.
With the intention of helping a patient. The person who is transferring that patient to the hospital firmly believe in their heart, they're not thinking, I'm signing this patient up for additional harm. They're thinking they are doing good for that patient. And that's where we get into that conflict of, are we doing good for this patient, or are we doing harm for this patient? And that's where the world of ethics tries to help clarify and help address those types of questions of, and again, language. The situation is the situation. The patient is the patient. We're using these words to try to understand the situation more, but then whenever we're breaking it into the words is how we're thinking rather than the reality, which is the patient is the patient. Again, going back to Wittgenstein, he would argue that when you try to describe something in language, you immediately minimize the truth of it. The truth is the truth. An example we use is, say you went on a vacation to Aruba and you came back. There is no amount of words that you could use to describe it that would give me the exact same experience as having gone on that trip. You at Aruba is truth. When you try to tell me what it was like, oh, the sand was so wonderful, the water was perfect, the food was amazing, I can get an idea of what that is, but that's not the same thing as having experienced it. So when we think, are we doing good for this patient? Well, the experience of that good is more meaningful than the true, what does the word, are we doing good mean? And that's that divide between the reality to the language is, I think, one of the biggest troubles in philosophy.
Oh, Ryan, it's so well said. You know, and going a little bit off topic in regards to this, but moving away from our slides for a second here, I'm so intrigued by this statement of good, bad, those types of things. So you mentioned before about you had seen a number of good death and a number of bad death. And I think that that's a very interesting, going back to this, the aspect of the language there, because I would agree with you. I've seen a lot of patients who have died very well, and I've seen a lot of patients who I look at that and using my own personal biases, like you said before, and be like, that was a horrible way to pass, right? Like, I personally, someone who works in the hospital, as well as a nursing home, as well as in hospice, the idea of being coded while I'm dying is probably the most horrific aspect that I can think of in the way of being a bad death, right? Now, in the setting of it being a 45-year-old in a car accident, you know, doing the best that we can in order to try and help that person, yes. But when I'm coding a 95-year-old, you know, and breaking their ribs every single time when I do a compression, that I look as a bad death. So how do we come up with what is a good death and a bad death in regards to, without injecting our own biases? Is there a way to do that, or is there not a way to do that?
Open communication, better discussions. A good example of this, if anyone has ever met me and ever heard me lecture, they've probably heard this, because this is probably the most powerful, meaningful moment of my life. Was I had a patient and I got called in for a non-beneficial fetal care determination. Patient was in her early 90s. She was non-responsive. She weighed only like 90 pounds, 80 pounds. Metastatic breast cancer, just active multi-system organ failure, just she was dying. And the family were saying, do everything, do everything, do everything. And the doctors come to me, they're saying, do everything, there's nothing more we can do, she's dying, and they don't get it. Can you go in, like, can you get involved? And I said, absolutely, I do my work. And I talked to the attending after just a couple of minutes reading through the chart. I go, has anyone said that she's dying? And they said, oh yeah, we've absolutely said that she's dying. I go, no, you haven't. You said extremely poor prognosis, no expectation of meaningful recovery, and highly unlikely to return to baseline. I know what that means. They don't know what that means. And they're like, what do you mean? That's clear. I'm like, no, they need to hear the words dying, death, dying.
Mm-hmm.
And I talked to the doctor, like, let's go in there and say it. So we go into the patient's room and we look at their children, the husband, and say, no, the dad and the two children. And we said, she is dying. If we do everything and keep her on the vent and pressors and resuscitate her, she's going to live 48 hours. If we take her off everything and only focus on comfort and just allow her death to come as peacefully as possible, she's going to live 48 hours. Now, what do you want to do? And the family said, we didn't know we were at that point. But she's been sick for so long. She's been fighting this. We thought that this was just another hospitalization, that she was going to maybe not return to baseline, but she'd pull through. And we know poor prognosis, she's dying. Like we've known for years, and no expectation of meaningful recovery. We know she's not going to be a professional basketball player anymore, but we thought we could get more time and engage with her. We didn't realize, like, this is the last hospitalization. Let's go comfort measures. And we moved the change the code status away from full code or CPR to full comfort measures only. And she passed the next morning, and it was a good death. And as you're saying, I would see keeping that patient as a full code as a bad death, because that's not what that patient would want, and that's not what that family would want, because they want the hope of more time. But whenever they come to that acceptance of, no, we've done everything and this is her time, then they're at peace with it. Then it became a much better death. So both result in the patient dying, and both are sad and tragic, and nobody will ever say that death is good, but there's definitely better ways than others. And whenever you see it done well, you understand what a good death can be in comparison.
That's well said, Ryan. Well said. Well said. All right, let's jump into, we've kind of a little bit talked about this. I think your last statement very much clarified the quality of life in regards to allowing that patient to have that natural death, as opposed to the continued progressive aspects of ongoing aggressive care, intubation, chest compressions, etc., because there's the no hope of improvement. But I think it's really important what you said about the clarity of language, because if you don't have clarity of language, then you're not going to be able to acutely communicate that to patients' family members who are already in a heightened emotional state because of the fear of losing someone. And I think that when people go into the hospital, a lot of the times, especially if they're intubated, everybody knows at a very basic level that breathing tube is bad, right? That's bad, and you're on life support, or that you're doing those types of things. And so clearly communicating that is very helpful, especially if someone has been, like you intimated to, another hospitalization. So if someone's been sick for a long time and has had multiple hospitalizations, and speaking on behalf of the medical community, we're somewhat good at our jobs, and we can help to keep somebody moving along for a long period of time. And so I think that can sometimes get confused if we don't use that clarity of language.
And that comes back to our ideas of euthanasia, and some of the difficulties with the conversation we have is when we use the term quality of life, what does that mean? Well, it means something different to everybody. Everyone has their own definition of quality of life. And then there's quality of life, and then there's a life not worth living. So I play sports, I'm very active, and I'm engaged. If you told me I needed to have a above-the-knee amputation, an AKA, how would I respond to that? Well, would I think losing my leg is quality of life? No, I think that would be a very diminishing of my quality of life. Would I think that losing my leg would make me live a life not worth living? No, I'd probably be okay with the amputation and just change my life in accordance to that. So those are two really different. I want to have both my legs, but if I'm not able to have both my legs, that's still a life that I'm willing to accept. And we see that when some patients make decisions on, I'm ready to die, others are kind of putting themselves in their shoes and saying, well, if I was in that situation, I wouldn't be ready to die. That would still be quality of life to me, but it doesn't matter if it's quality of life to you. It matters if it's quality of life to them. And that's, as an ethicist working in the hospital, is one of the most important stresses that we have is when we're determining quality of life, only patients are allowed to determine quality of life. Family members and physicians, we are not allowed to say, that's a life worth living and that's not a life worth living. We can have that conversation with them and we can engage with what that means, but really the only person who can make that decision is the patient themselves.
That's wonderful, Ryan. I like that aspect because it's something that we talk a lot about. I do talk a lot about quality of life, and I've always felt very strongly that it's very unique and dependent upon that specific individual and how they would value it. And I always think of that from the perspective of my own father, and he was very clear in regards to what he determined quality of life. And so I think that it's always interesting from that perspective because I've seen the gamut, right? I've seen the gamut of people saying quality of life for me is being awake enough to watch television and laying in bed and being in a long-term care facility. And I've had other people who've said if I can't be active and functional in my own activities of daily living, that's not quality of life for me. But I really love the added aspect of it is this a life not worth living? Because I think that's a really unique perspective on it. And I think the example that you gave about the above the knee amputation is a really valuable aspect, especially to a younger individual. So, because it would dramatically change their quality of life. No, very, very, very important there. So you mentioned a little bit in regards to the legality of euthanasia. And I don't want to spend a ton of time on this, but what is the question that I have is this is the third aspect when you first started us off in regards to a person having the ability to make the decision, I want this, help me to do this, give me something to move that along. And what is the ethical rationale that it's okay in some of these states and not okay in the rest of the world or the rest of these states? So if you wouldn't mind just kind of at a high level giving us an overview on that. I know it's a big question and a big ask there, Ryan, but can you help distill it down a little bit for us?
So the ethics is still in debate. We're still discussing it from just a large scale of, is it right? In terms of the states, we feel that it's state rights. They do the votes and the people have accepted it. And it's also the creation of a program that not everybody has to participate in. This is giving opportunity to patients who do want to participate in it. But if you are a patient who absolutely would never want to participate in it, there is no forcing of anyone to go into that. That's one of the aspects of it. And I think the system in the United States, again, I could say my own personal biases, I don't know where I stand on physician-assisted death and medical aid and dying. I understand patients should be allowed to make their own decisions, but I also kind of don't feel like it's right to be prescribing death. But I also feel that patients should be allowed to make that decision. So some days I'm on one side, some days I'm on the other, and I'm really not sure. So I can try to be as unbiased as possible. But I think the system that we have in the United States is as good as it could be. Patients have to be on hospice, which means they have to have a condition that has a less than 6-month life expectancy. So they have a prognosis of less than 6 months. This is not a patient who is in their 20s and gets a paper cut saying, well, I think I want to engage in physician-assisted death. That patient would not qualify. You have to have metastatic cancer. You have to have end-stage renal. You have to be expected to die in the next 6 months. A patient has to engage with a physician. Patient has to bring it up. The physician does not approach the topic. The patient approaches the topic. Then the patient is written a prescription or has a discussion. Then they come back. I think they have to do a reassessment a week or 10 days later. It's different in each state. They have to restate that they still want to participate in that. If there is questions of their mental health, they have to see a approving psychiatrist to make sure that they are not speaking through depression or speaking through a mental illness. They have to take the prescription, they fill the prescription, and then the biggest thing is patients have to self-administer the medication. A physician is not allowed to administer the medication. A family member technically is not allowed to administer the medication. A lot of patients have difficulty swallowing, so what we see is it comes as a pill. A lot of patients will grind it up and put it in a glass of water and then drink that glass of water. And another thing that I think is really interesting is in that process, the patient takes it at the last moment. And there's a longer step along the way. And that's really trying to go to that autonomy thing of, is this patient really wanting to engage with this? Are they taking their time? Are they thinking about this? They have to come back. Have they really thought about this? And it's really trying to stress, do they feel like they're being forced into this, or are they truly trying to represent their autonomy and express themselves? And is this something that they want to engage with? And that's the self-administering. That's where we're talking about the involuntary passive or involuntary active euthanasia. The self-administering is a step designed to eliminate that, where only the patient is allowed to administer it. That means you can't have involuntary active euthanasia because that will be somebody else administering it. It does bring up some ethical questions. So I know ALS, Lou Gehrig's disease, where patients lose the physical ability to engage with it. Should those patients be allowed to have it administered to them? So, but those are more rare and cutting hairs kind of situations of semantics rather than what is kind of established. I think the self-administered thing is a very good step, and maybe we can have some carve-outs for some particular situations, but for the most part, patients have to purposefully engage with it. It does bring up some questions of justice and allocation of resources because this is a standardized medication. It can be expensive. Insurances may not want to pay for it. It may not be available to all patients. If you live in a rural area, maybe the pharmacy won't fill it. There's a lot of aspects of it that need to go into it, but it's designed for patients to engage with it in a safe, processed way that a patient who is dying take it in their hands. And another thing that I know in Washington was always interesting was we were working on is when a patient dies through physician aid in dying, their death certificate says their underlying condition. So it will say they died of cancer. It will not say that they died of suicide or physician-assisted suicide, because that can bring up life insurance issues. And like, did this patient die? They died of their cancer. They died of their terminal disease. They chose the timing in which that disease finally took their life. But it's always that underlying condition that caused the death.
That's wonderful, right? And I think that taking that time to clarify that is so helpful, because as a hospice physician, when we're first doing introductory conversations with patients who have been referred to hospice, and a lot of the time that's a patient who doesn't know much about the death and dying process as of that moment, right? They understand that they're sick. They understand that maybe they have bad cancer. They understand that there's maybe no other treatment options to them. But a lot of the times questions arise, and sometimes patients and or their family members will ask these hard questions of us as hospice and saying, well, this is what you're doing. They think that we're doing this process of physician-assisted suicide. They don't understand that it's a separate type of medication, that it's not legal, for instance, in Kansas or Missouri. And so we don't participate in any of this in the hospice that I'm involved with. And so they look at that, though, as the medications that we're using to assist the patient in alleviation of their symptoms. They think that those medications are doing this process. And so we have to really be very clear in regards to, I had a conversation the other day with family members in regards to a patient with severe COPD. That was their hospice diagnosis. And they were really struggling for air and exhibiting significant aspects of air hunger. And as you know, Ryan, we utilize morphine to help with air hunger. Well, this person was relatively savvy, and they were like, but morphine suppresses someone's respiratory drive. You're giving them morphine and suppressing their respiratory drive when they have COPD. And they were putting that process together and saying, you're assisting them and helping them to die. And I said, no, we have to be very clear in regards to that. I am not assisting this patient in regards to helping them to pass. I am alleviating a symptom, and that symptom is air hunger. And we have to be very clear in regards to that. And I think that that comes back to, again, the words. But I think that you did a beautiful job helping to explain that physician-assisted suicide, death and dying, those types of processes are totally different and separate. And that one of those conditions, of course, is being on hospice, but it is not mutually exclusive, and they have to seek that information out. And I do agree with you. I think this patient-initiated process is a great, stopgap or backstop to make sure that they're respecting that autonomy aspect of it. So,
and
for sure.
going back to the autonomy, the statistics that are coming out. So Washington has had it legal for about 8 to 9 years now. They engage with patients on why are they doing this, and they publish it every year, the results. And it's fascinating that the number one reason, it's every year, the number one reason patients engage in medical aid and dying is a sense of loss of autonomy. It is not uncontrollable pain and suffering. It is not burdening to their family. It's a sense of their life being taken from them, and this is a means of taking control of their life back. It's my cancer is not going to tell me when I die. I am in control of my life. And a lot of patients, it's actually a majority of patients, will fill the prescription and have the medication and never actually take it. It just sits in their bedside drawer, but they know in the back of their mind, I can take it when I'm ready. That doesn't mean I have to take it today. Maybe I'll take it tomorrow. Maybe I'll take it the next day. But they have that sense of control and autonomy of I can engage with this when I do. And sometimes they pass in a peaceful way that they never actually need to take that medication, but they have that security. They have that sense of feeling of I have it if I need it. Not that I need it today, but when I need it, it's there for me. And that, I think, really goes into a deeper statement of what's actually in pain. And when we talk about harm and we talk about suffering, there's physical suffering, but then there's also moral suffering and emotional suffering and spiritual suffering. And spiritual, emotional suffering can be just as intense, if not more intense, than the physical suffering that some patients are feeling. So while we think of euthanasia as alleviation of only physical suffering, it can also be an alleviation of the emotional and the spiritual suffering that that patient may be feeling, of having everything about their life being taken away from them, from their strength to their health to their time on this world. This is an opportunity for them to have some semblance of control come back into their life.
That's really interesting. And you utilized the diagnosis of ALS in particular, and some people may recognize that as Lou Gehrig's disease, but I think that's such an interesting parallel, because that is such a disease that just strips people bare because they're cognitively intact, but they lose all aspect of the ability to care for themselves. And so I can see that from that perspective and why that would potentially need to be a carve out in some of those situations. All right, and I think we've covered these types of aspects in regards to the differentiation of terms and assisted suicide. So we have kept you here for 52 minutes, Ryan, and this has been an absolutely incredible discussion, and you have really opened, I think, a lot of opportunity for people to continue to expand on this learning. And I just really appreciate the opportunity that you've given us today and our audience to be able to learn from you. And I just love to give you the opportunity of where can people find out more about you, or where can they engage with you?
Sure. Again, thank you for the opportunity to be here. I love being able to share and help improve people and help provide some level of education. I'm a philosophy student who actually gets to put it into practice and help other people. So I'm always appreciative of those opportunities. I work at the Center for Practical Bioethics. You can find us at practicalbioethics.org, and we're also on all the social medias, on LinkedIn, Facebook. I believe we have a Twitter or an X account or whatever that it's called now. But we're a nonprofit in the Kansas City area, but we also serve nationwide. And we really work on clinical, artificial intelligence ethics, social determinants of health, advanced care planning, a lot of different aspects. But you can reach out to me or our organization. We have a lot of opportunities, trainings, education programs, and initiatives to really help spread the goal of informing patients and informing providers to be able to do this together. We utilize a shared decision-making model of patient and provider pulling in the same direction with good communication, open language, and clarification of goals. So whatever we can do to help foster that, we feel everybody benefits when the right things are done well.
Ryan, thank you again so much for your time and energy, and definitely we're going to have to send people to the Center for Bioethics. So thank you so much.
Thank you.
Very appreciate it. Take care.